is about the role of steroids in tuberculosis, especially in Indian scenario. Firstly, pericardial involvement. It is demonstrated that benefit in fibrinoeffusive tuberculous pericarditis in terms of survival, resolution of clinical symptoms, and need for repeated pericardiocentesis. So, pericardial involvement is of definitive benefit with it's got a definitive benefit with steroids. Adjunctive prednisolone in the treatment of effusive TB pericarditis in a HIV positive patient has a significant reduction of mortality. Next thing is TB meningitis. Adjunctive steroids offered an advantage over antituberculous chemotherapy alone in management of stages 2 and 3 TB meningitis for survival and also for the frequency of development of neurological consequences. However, changes in intracranial pressure or incidence of basal ganglia infarction was not significantly affected. So, administration of steroids has been found to be most beneficial in patients with complications of tuberculous meningitis. It may also be useful in the management of complications such as raised ICP, cerebral edema, stupor, focal neurological deficit, spinal block, hydrocephalus, and basal opticochiasmatic pachymeningitis. The recommended daily dose is 0.75 to 1 mg per kg per day in adults and 1 to 2.5 mg per kg in children. So, what are the possible indications for steroid in TBM? The clinical indications are stages 2 and above, evidence of raised ICP, focal neurological deficits which are suggesting arteritis, and radiological signs like cerebral or perilesional edema, hydrocephalus, infarcts, opticochiasmatic pachymeningitis. What are the stages in TB meningitis? Stage 1 means patient is conscious with or without neck stiffness, no focal neurological deficits, and no signs of hydrocephalus. Stage 2 is conscious but confused, has focal signs such as cranial palsies or hemiparesis. Stage 3 is comatose or delirious with or without dense neurological deficit, and stage 4 is deeply comatose patient with decerebrate or decorticate posturing. So for stages 2 and 3, steroids are most beneficial. Coming to a patient with any chronic meningitis which turned out to be tuberculosis, for these patients, empirical steroid therapy is inappropriate because it can result in rapid progression of undiagnosed fungal diseases if they are present. Intracranial tuberculoma. Short course chemotherapy may be adequate for the treatment of tuberculoma, although its efficacy is not yet established. But corticosteroids are helpful in selected patients who have cerebral edema and are symptomatic. So, for intracranial tuberculoma, it is our choice based on the clinical picture for that particular patient. They are useful if the patient is having any cerebral edema or any other symptoms related to this, or else just ATT is also enough. Tuberculous pleuritis. The definitive usefulness of adjunctive steroid in the management of TB pleuritis has not been thoroughly established. Evidence regarding efficacy of steroids in treatment of pleuritis remains insufficient. Some randomized controlled double-blinded placebo trials have been done, but all had important methodological differences, and there was no benefit in the use of steroids in two controlled studies in which therapeutic thoracocentesis was performed. However, the duration of fever and time required for fluid resorption were decreased in a third of study in which no therapeutic thoracocentesis was performed. Administration of steroid did not influence residual pleural thickening in any of these studies. So, based on these data, routine use of steroids cannot be recommended in TB pleuritis and should only be used if acute symptoms such as fever, chest pain, dyspnea are disturbing to the patient. If needed, steroids should be prescribed only after institution of appropriate anti-tuberculosis treatment. Patients can be started on steroids with 0.5 to 0.75 mg per kg weight of prednisolone or equivalent until acute symptoms have subsided with rapid tapering thereafter. Rapid tapering should be done and there is no need to continue the steroids. Coming to endobronchial therapy. This is another condition like TB meningitis where we prefer giving steroids. Corticosteroids have been used empirically with ATT in some cases to prevent bronchial stenosis. Steroids may suppress the barking cough but may not alter the course of the disease or prevent bronchostenosis. Hypersensitivity reaction associated with anti-tuberculosis therapy is another situation where steroid may be beneficial. Local endoscopic injection of corticosteroid in endobronchial tuberculosis lesion has been described in one case report. Some studies have suggested a positive role of steroid therapy in children with lymph node tuberculosis causing bronchial obstruction. However, the benefit of corticosteroids in this situation is speculative, and a recent randomized trial in adults with endobronchial TB have failed to show any beneficial effect. So, the efficacy of steroid in endobronchial TB has been equivocal. There has been some interesting but anecdotal data on the use of local steroids in management of this condition. Endobronchial TB is frequently undiagnosed complication of pulmonary TB. It is often overlooked as bronchoscopy, as a bronchoscopy, which is key for diagnosis, is not always performed in these patients. The presentation may precede or occur concomitantly or occur up to 17 years after the diagnosis and treatment of pulmonary TB. Bronchoscopy should have been considered in any patient with a history of pulmonary TB and symptoms suggestive of endobronchial TB. Treatment involves antituberculous treatment along with bronchoscopy procedures or surgery as indicated. The role of adjunct corticosteroids is still unclear at this time, but usually it is preferred. In abdominal TB, the role of steroids is not well established and should not be routinely administered in patients. Coming to granulomatous hepatitis, in country like India, when the etiological cause of granulomatous hepatitis is unclear, a therapeutic trial with ATT is often given. If this fails, then corticosteroid treatment may be tried. In the study of idiopathic granulomatous hepatitis, the disease resolved spontaneously in 7 patients. 2 patients responded with less than 3 months of oral steroids or indomethacin treatment, and 7 patients required steroid for 2 years or longer to maintain a symptomatic state. Coming to peritoneal tuberculosis, some studies suggest that steroids administration in combination with anti-tuberculosis therapy could reduce morbidity and mortality in peritoneal TB. And in some other studies, adjunctive steroid therapy could be beneficial in causing defervescence, improvement in serum albumin, gain in body weight, and radiologic improvement more rapidly in TB patients with toxic reactions. Paradoxical response to ATT has been found to improve with corticosteroid therapy. Such response, presumably due to immunological awakening, has been reported to be more common among HIV patients with TB, especially after initiation with ART. Furthermore, corticosteroid treatment was reported to result in a favorable response in some HIV infected patients with disseminated tuberculosis.